Good morning, everyone. I'm Mohanad Hamandi, a second-year cardiology fellow at Mayo Clinic in Rochester. It's a pleasure to be joined by Dr. Adam Greenbaum following his presentation of the PROTECT head-to-head trial at ACC 2026 in New Orleans. Dr. Greenbaum, thank you for being here. To start, what motivated this head-to-head comparison between Emboliner and Sentinel, and what key questions were you aiming to answer from this trial?
Great question. Stroke is certainly probably the biggest feared complication by patients when they undergo TAVI. It still happens, and it'd be great if we could reduce that or make it close to zero. We have cerebral embolic protection devices available in this country, but outcomes have been variable, and I guess our ability to prove their efficacy has been difficult. And maybe that's because they're not perfect.
Yeah.
So companies have developed newer generation embolic protection devices to hopefully overcome some of those limitations, and maybe eventually could be proven to be more efficacious. So the Emboliner device is a next generation embolic protection system. Does not directly cannulate the great vessels. It is a soft mesh double layered filter that sits in the aorta from the ascending to the descending, draping over the vessels. And it actually also has a basket that would capture any debris that would also go downstream to the spleen, to the kidneys, to the gut. And it has a port where you could actually access to get your delivery systems and other equipment through. It's delivered through a 9.5 French integrated sheath in the contralateral femoral. So that's the device. So the trial was designed to test the Emboliner against Sentinel. So this is the first randomized trial between two cerebral embolic protection devices. It was designed as a non-inferiority trial in terms of a combined safety and efficacy endpoint. The primary endpoint was death, stroke, or acute kidney injury at 30 days.
Okay.
The secondary endpoint was just stroke alone, also powered for non-inferiority. And another secondary endpoint was debris capture. Debris capture was powered for superiority. So one-to-one randomization, people getting TAVI with either a balloon expandable or self-expanding device. You get randomized between Sentinel and Emboliner, and those were the endpoints.
Gotcha. Excellent. And the other question that I have is that do we think that we are overestimating the importance of embolic debris following TAVR or during the TAVR procedure?
In terms of overall, the fact that the risk of stroke is low in general and that we haven't been able to definitively prove.
Yeah, and that the debris capture did not change the stroke rate, basically.
Right. So I think well, let me start by saying that I am still a believer in embolic protection. I like to say that any embolic debris during any procedure that we do is neutral at best, right? I can't come up with a reason why you would want to have that. So it's neutral at best and potentially and maybe likely harmful.
Yeah.
I don't really want embolic debris going to my kidneys either during a procedure, right? So maybe it bypasses the brain. And when you look at these filters, right, we catch the particles in almost every procedure. And by the way, what's interesting is the particles that are caught is thrombus and arterial wall. I mean, there's no doubt these devices are scraping the arterial wall, valve material. So it just makes inherent sense that if you could capture this debris, it would be good for you. Now, why haven't we been able to prove it definitively? Personally, I think because there's too much noise in the system. For instance, the historical endpoint has been a 30-day endpoint.
Yeah.
And the reason for that may be partly because you need a number of events to occur
Hmm.
for any statistical analysis, right?
Yeah.
But if you think about it, what I'm most interested in, and I think what most structural interventionalists are interested in, is what happens on the day of the procedure, you know,
Yeah. Yeah.
while the filter's in place and shortly thereafter. If you
Hmm.
actually look at what I refer to as day 0 and day 1, meaning up to the next morning, because I'm willing to say that any stroke that occurs to the next morning, I will say is procedural related.
Hmm.
But when you start to get into day 3, 4, 5, day 15, day 25, it's hard to say that that's procedural related, right? I mean,
Yeah.
these patients
Yeah.
have atrial fibrillation. They're not on
Mhm.
anticoagulation, sometimes surrounding their procedure because someone's worried about, access site bleeding, or they can't
Yeah.
take anticoagulation. Things happen to them in life. They have comorbidities. You
Yeah.
can't ask these devices to protect against a stroke on day 20, right? So
Yeah.
I think we need to just do a larger trial with a much shorter time frame, and I actually think we could prove it. In this trial, by the way,
Hmm.
if you just not a primary endpoint and not a secondary endpoint, but if you look at what happened in the first 24 hours, there were 4 strokes on the Sentinel arm and only 1 stroke in the Emboliner arm.
Yeah.
You
Yeah.
know, low numbers, but I would say something to think about.
Yeah. 100%. And speaking of comorbidities, do you think that the use of such devices can be tailored to specific population that can benefit from the protection the most?
I do. I also think that just like anything, there's probably a range of risk. I mean, if
Yeah.
you look at the Partner 3 study, low risk TAVR, we're talking about a stroke rate of less than 1%.
Yeah.
But if you just look at real world TAVR, because we're not just doing
Yeah.
TAVR in patients, it's about 2%.
Yeah.
Okay.
Yeah.
But if you look at bicuspids, if you look at valve and valve, it may be as high as 4%.
Yeah.
And
Yeah.
actually, in the TVT registry, if you look at stroke rate in those two populations,
Hmm.
in patients that successfully had Sentinel placed, it was cut in half to 2%. So it's hard to say that the devices don't work, right?
Yeah.
Uh,
Yeah.
the problem is sometimes you can't get the Sentinel device in, right? If you look at success rates of technical
Yeah.
success with Sentinel, it's probably in the 85% range. I mean, it's just sometimes you can't get both baskets open. Sometimes the radial and arm anatomy is not good. Sometimes the subclavian and the innominate really tortuous. So maybe a device that could just easily be placed in the aorta would work better.
Gotcha. Okay. And so, given that the trial showed basically similar outcomes between those devices, what makes you pick one over the other during any TAVR procedure?
Right. So that's probably still to be worked out, right? I
Okay.
mean,
Okay.
for the structuralist. I mean, look,
Yeah.
the trial was designed and started in May of 2023. The first patient was enrolled. That was
Hmm.
before the
Okay.
results of Protected TAVR were even published.
Okay.
And then
Gotcha.
even after Protected TAVR was published, the question about disabling, non-disabling, everyone thought would be further proven in the British study, right? So in the
Mhm.
UK study. So the trial was designed as non-inferiority, assuming that Protected TAVR and then the subsequent study would be positive. Um, so right now you have statistical evidence that they're that it's non-inferior.
Gotcha.
But it was superior, easily superior in terms of total debris capture, total particles, mean particle, particle size of 150, particle size down to 40, whatever metric you want to use for debris capture, it was superior.
Okay.
And more importantly, there was higher success rate.
Mm,
Technical
okay.
success, meaning the core lab said at the time, if you look, the core lab defined technical success as all the intended vessels were covered the time the valve was deployed. That
Hmm.
was
Okay.
95% in the Emboliner arm and only 85% in the Sentinel arm. So
Gotcha.
to me, I guess you could start looking at anatomy,
Hmm.
right? Is the radial anatomy favorable to actually get both filters easily in. Is the femoral, on the other hand, is the contralateral femoral look good? A 9.5 French sheath as opposed to, a smaller sheath.
Yeah.
Interestingly, there was no excess of vascular complications or higher bleeding from the contralateral sheath. I think structural interventionalists now are pretty good at sheath management.
Yeah, definitely.
But let's just say you had a really calcified
Yeah,
contralateral
vessel.
femoral.
Yeah.
Maybe that patient you'd use the Sentinel. But for me, I don't know. I'm really intrigued by the basket that actually catches debris from going downstream elsewhere. The incidence of acute kidney injury,
Hmm.
stage 3 acute kidney injury, 1 in the Emboliner arm and 3 in the Sentinel arm. Again, these are not statistically different. The trial was
But there
not
are signals. Yeah.
it just wasn't powered to show these differences. But you have to start, when you start looking at these numbers, you start to wonder.
Yeah. Yeah, definitely. And that brings me to my next question regarding like the systemic capture. Do you think that future trials could be designed to like capture events like mesenteric ischemia, kidney injury, or limb ischemia to show that
I
benefit?
think those are all great topics for investigation. Because think about this. Remember, it was pretty common that people were talking about all the MRI hits,
Yeah.
right? Maybe it
Hmm.
wasn't a stroke, but it was going to lead to cognitive decline down the road, right?
Yeah. Yeah.
Well, what my guess is if you scan the kidneys, you'd find similar hits in both kidneys in all these patients. And maybe it's not enough to change the creatinine the next day or day
Yeah.
3. But what
Yeah.
about, could it possibly be that,
Yeah.
well, as they lose more nephrons, they go on to get kidney failure a couple of years ahead of somebody who didn't have those
Yeah.
embolic hits to the kidneys? I mean, why wouldn't we look at other organs in the same way? So I don't think anyone's going to do a 10-year study,
Yeah.
follow-up of an embolic protection device specifically for kidney function. But it is kind of interesting to think about.
Yeah, definitely. Well, I think the last question that we usually ask is targeted towards fellows in training interested in pursuing interventional structural career. What advice do you have, and what exciting times lie ahead in the future?
Yeah, I think you got to follow your dreams, right? If you like to do structural work, you do it. Don't worry about the additional year that it takes. I think the field will continue to explode. I mean, there's just more and more really, really ingenious solutions that are being proposed for a lot of this valvular heart disease. I think it all comes together in the end because the end result of all valvular heart disease and um, even coronary disease and hypertension, it's all heart failure, right? So now we're actually seeing therapies specifically designed for heart failure, which I think is also a new field with some really, really interesting devices to help heart failure. My overall advice for anybody entering the field, as you know, is don't let anybody tell you it can't be done. If you have an idea, run with it.
Great. Well, thank you so much. We really appreciated your time. And for more videos, please follow our X account and YouTube, Fits on the Go. Thanks so much.
Really my pleasure. Take care.